Okay, good morning, good afternoon, good evening po sa lahat. Saan mong pong panig kayo naroon sa mundo. Welcome po to our 177th episode of the Stop COVID-19 webinar series. And Happy New Year po sa inyong lahat. Maraming salamat po for being part of our credible online community, and to all those who have just discovered us today, welcome po, and you are starting your 2024 in the right way po. In the dynamic landscape of healthcare, the Philippine Genome Center stands at the forefront of groundbreaking advancements, spearheading a transformative era in medicine that promises tailored solutions for every Filipino. Genomics and its applications perform at the PGC. They provide insights into how this revolutionary science contributes to precise and effective healthcare interventions, and from unraveling genetic basis of diseases to crafting personalized treatment plans. Genomics holds the promise of saktong lunas for every Filipino, ensuring that healthcare is not just universal but also tailored to individual needs. Kaya po sa ating unang episode for the year 2024, our esteemed panel of experts will discuss the pivotal role of genomics and what it plays in reshaping the practice of medicine across the Philippines. And as we navigate ito pong panahon po na tinatawag na personalized healthcare, precision medicine, understanding the unique genetic makeup of individual Filipinos, very crucial and an indispensable tool in diagnosis, treatment, and prevention. I'm Dr. Raymond Francis Sarmiento, Director of National Telehealth Center, National Institutes of Health, University of the Philippines, Manila. Always a pleasure to be with all of you during our regular Friday po, no? Our first of many for the year 2024. And again, honored to co-host this program with our adjunct research faculty, also international renowned public health communications expert, Dr. Susie Pineda Mercado. Dr. Susie?
Hi, Raymond! Good afternoon sa inyong lahat and Happy New Year. It's great to be back and to have all of you with us. We would like to welcome all of you who are on the live broadcast of the Zoom webinar, and all to those who are watching via live streaming on TV, YouTube channel, as well as the UP Systems Facebook page, TV UP Facebook page, Stop COVID Deaths Facebook page, and of course, all of you who are watching from TVUP Signal TV Channel 101. Raymond, before I go to our guests,
Yes, go ahead.
I wanted to just talk a little about our topic, no? Kasi it's sabi mo, personalized medicine and healthcare and looking at the genetic makeup. And I was just going to share with our audience, recently, I took a blood test, which
Saan yan?
supposed to test for 5 types of cancer.
Okay.
Sila Dr. Obia lang nun eh. And apparently the sensitivity is quite high, but it's not a perfect system yet. Pero nakaka-screen na sila. They can see if you have early signs of cancer through a blood test. Isn't that amazing? That's so amazing. And then I remember when I was in the US naman, so mga kababaihan who are listening, diba pinapap smear tayo. Sa kanila, when you reach a certain age, hindi ko na sabihin yung age kasi yung age. Anyway, you reach a certain age, they do a pap smear and then they do a DNA test on it. And if you're negative, you never have to have a pap smear again. So I think there are lots of new things that are evolving. Most people, just hear about it in the news or nababalitaan. And when we think about, certain conditions that might be hereditary, I think in the future we will begin to see more and more how we can prevent or do an early detection of conditions so that they can, parang maagapan ba? Di ba ganun yun, Raymond? Parang maagapan ka agad di ba? So anyway, stay with us. It's a really interesting topic. And our main presenter is Dr. Eva Maria Cutionco de la Paz, one of our favorites, who currently serves as the Director of Health Programs for the Philippine Genome Center, and also is the Executive Director of the National Institutes of Health, University of the Philippines, Manila. Our reactor is Dr. Felicitas Lakbawan, who is Executive Director of the Philippine Genome Center. Naku, talaga naman, we really bring you the best speakers and we are so grateful to them for ano yun, kinakarir po nila yan, ano, yung mga presentation sa inyo. Di ba, Raymond?
That's true.
Parang
That's true.
they really prepare. All right. So, as you've seen on our opening billboard, we have transitioned. We started out just talking about COVID. And in fact, Raymond, a few weeks from now, we might even change the title of our show, no? Parang meron na tayong mga suggested topics.
Suggestions,
Pero
yes.
baka may suggestions din kayo, lagay nyo sa chat box, no? So we're trying to, we might be changing the topic, I mean the title, and then, but we'll still continue to cover things the way we have been covering them. We will have, what do you call this? Still have the experts of PGH, UP, and all the other medical centers where we have experts. And we'll try to continue to bring you the latest updates, the latest information, maybe later on some independent news bulletins from our group that has no name, the no name group. Okay, so before we go to the Philippine Genome Center, Raymond, I think we have the person on the street. Ay, by the way, to all our friends, 1 hour lang tayo ngayon. So we have tried to now tighten the show because we have feedback na, sometimes hindi natatapos kasi mahaba. 1 hour na lang tayo ngayon. So we go straight into our person on the street and later to our presenter. Raymond, over to you.
Thank you, Dr. Susie, for our person on the street video po. And person on the street is what we use po to set our discussion into context by interviewing kung ano po yung alam ng common folks on the street about our topic at hand. Some guide questions that we pose include, meron ba kayong mga kapamilyang mataas ang kolesterol? Saan ba ito sa tingin ninyo nakukuha? At alam nyo bang may klase ng mataas na kolesterol na namamana? So those types of guide questions po ang makikita po dito sa ating short PATS video. Please watch this.
Meron akong mga kapamilyang medyo mataas yung cholesterol. As close as yung parents ko po at kapatid. At saka mga tito at tita.
Opo, yung mother ko po is na-diagnose ng high blood noong year 2015.
Sa ngayon, wala. Normal lahat kami ng mga kapatid ko.
Yeah, both parents ko. Mataas yung cholesterol nila.
Sa tingin ko yung diet po nila talaga, tsaka yung lifestyle. Hindi sila madalas po nag-exercise. Meron sa kanila, katulad ng kapatid ko, kaso hindi pa nakakatulong na dahil sa aming lugar na pinanggagalingan. Medyo marami kami kinakain na nakakataas po ng cholesterol. Katulad po ng mga pagkain baboy at saka mga fatty foods na mamantika.
Nabanggit sa akin ng mother ko na nakuha niya sa pagkain ng fatty foods or mga foods na high in cholesterol.
Siyempre, pagkain ng mga matataba, yan. Number 1 yan. Pag mahilig ka sa mantikaing pagkain, yun, makakuha ka ng cholesterol.
Based din sa sa mga laging na-mention ng parents ko, whenever na mataas yung cholesterol nila. Sinexplain naman nila yun sa amin, sabi nila napapasa daw yun. Like, nakuha nila from sa parents din nila, ganun.
Aware po ako na mayroong mga condition, kaso nga lang hindi po ako sigurado kung alin po exactly ang mga condition na ito. Mas winawarningan po ako ng magulang ko na ang rason kung bakit nangyayari yung mga condition ito ay dahil sa diet at lifestyle, hindi po dahil sa namamana.
Yes po, narinig ko rin po na parang nasa blood din nila yung ganung sakit. So I think meron pero hindi ako familiar.
Alam ko ang cholesterol namamana yan eh. Pero hindi ko alam yung mga iba't ibang klase ng cholesterol. Pero siguro, pag may ganyan ka, parang ano yan eh, cancer, iba-iba yung cancer. Siguro sa cholesterol, ganun din. Iba-iba rin yung klase ng cholesterol.
Yeah, oo. Based din dun sa answer ko kanina, pero I'm not too familiar with it talaga.
Dapat may insurance kayo. Kung ako sa inyo, lalo na kung may lahi kayo, bawasan nyo yung pagkain ng mamantikain, yung matataba. Kumain kayo ng mga gulay, prutas, saka yung mga tinatawag na good cholesterol para ma-maintain yung cholesterol level niya.
Okay, thank you so much, TVUP. Just wanted to share po, no, a lot of those answers very very typical from what we usually expect. What did you think about the video, Dr. Susie?
Sabi ko nga yung masamang cholesterol, yung LDL, lechon de leche yun. That's the way to remember it. Kasi it's confusing, di ba? May HDL, may LDL. Pag sinabing LDL, lechon de leche. Pero I think the point is, Raymond, parang there are some conditions that we are genetically predisposed to, no? And again, I'll go to my own story, no? My father's cholesterol was always off the scale. So nung sinabi ko mataas ang cholesterol ko, sabi niya, ay, mataas ba yun? 800 na yung cholesterol ko. Bakit ganon? So I think it's a conversation around what are the things that you're sort of predisposed to, pwede mong manahin, and then what can you do in your own behavior and your lifestyle. But I think what our experts are going to talk about is how can we do early detection or find out how personalized medicine can actually help us so that we are what should I say? Parang we're ahead of time, alam na natin. Kung alam natin na ito na nga yung maaaring maging sakit, umiwas na tayo. Sige, Raymond, meron kayatang housekeeping?
Little bit of housekeeping lang po, no? So
Sige, go ahead.
we've already sent out all of our certificates from webinar 1 to 176. For those who are asking, only those who were able to spend at least 50% of the webinar duration dito po will be able to receive a certificate. And if you feel you should have received a certificate but did not, please email us at stopcoviddeaths@up.edu.ph. For today's webinar, we'll have a standard panel discussion format. And after our speakers have presented, that will be followed by a Q&A session. Okay, please go ahead and introduce our main speaker, Dr. Susie.
Okay, none other than Dr. Eva Cutionco de la Paz, who is the Director for Health Programs at the Philippine Genome Center, concurrently Executive Director of the National Institutes of Health in UP Manila. Eva, welcome again to the program.
Hello.
Si Eva.
Yes, go ahead, ma'am. Papa.
Yan, go ahead, Eva.
Magandang hapon po sa inyo lahat. Tanghali pa lang pala. Magandang tanghali, Dr. Susie and Dr. Raymond. Thank you for your kind introduction, and thank you for the opportunity to share about how genomics is transforming the practice of medicine. Saktong lunas para sa saktong Pinoy. Is that even possible po, no?
Mm-hmm.
So there's so much to... should I start already?
Yes, well, go ahead and share
Go
your
ahead, go
slides,
ahead.
ma'am. Mm-hmm.
Okay, so there is so much to share, but so little time. So I focused on the following: the impact of genomics on the practice of medicine, testing genes and actionability, unique issues in genomic testing, and just end with some key messages. So we now live in the genomics era, which
Ma'am, we don't see your slides if you're sharing it.
Oh, I have shared my slides. Oh, okay. So what do I do? We tested this earlier.
Yes,
So
ma'am.
ulit. Sorry. Yeah.
Okay, there we go.
Uy, ganda.
Okay. So this was my outline that I showed earlier. So the impact of genomics on the practice of medicine, testing genes and actionability, unique issues in genomic testing, and with some key messages. So we now live in the genomics era, and which promises a more efficient, more effective care that leads to better health outcomes. And this is because we know more about the human instruction manual, our DNA, found in each of our cells. So with genomics, it is possible to predict, diagnose, and treat diseases more precisely and personally than ever. We actually are more alike than different, since our genetic code is about 99.6% similar. However, there is that tiny bit of difference, about 0.4%, that explains why we have a set of features unique to us and why we don't look like anyone else in this Zoom room, except of course, if you are identical twins. So variations in the genome come in different forms. The most famous are what are called single nucleotide variants or single nucleotide polymorphisms, also known as SNPs. There are also variations like insertions and deletions known as indels, and also structural variants. Scientific research has determined how variations in our DNA sequences affect human health and disease. Genomics can actually provide answers to questions such as why you have had 3 bouts of COVID, while your partner who sleeps beside you never had one. This is related to genetic susceptibility to infection. A person's genetic makeup can also explain why, even if a person is so thin, exercises every day, eats the right food, actually has dangerously high cholesterol levels, just like what you mentioned earlier, Dr. Susie, and is at risk, actually, that person is at risk for a heart attack, even at a young age, because of a common condition called familial hypercholesterolemia. So genomics in medicine has far-reaching and exciting implications and a wide spectrum of uses for more accurate diagnosis. You can see that in this slide. Better patient stratification, improved risk prediction, more informed response to treatment. It can also be used for drug repurposing, and prognosis and identification of novel genetic associations and mechanisms. And these advances have resulted in a dramatic growth of genetic testing that are now available. On the left side of this screen, one can see the increase in the number of tested genes in green and the number of tested conditions in red. Notice the small number of labs able to offer genetic tests in purple. On the right, you can appreciate the steady growth of genetic tests offered since 2012. Genetics is the study of genes and their roles in inheritance, the way certain traits or conditions are passed down from one generation to the next. Genomics, on the other hand, refers to all of a person's genes, the genome, including interactions of those genes with each other and with the person's environment. Now, because of the advances in what we call now next generation sequencing technologies, testing has evolved from testing single genes to testing a panel of many genes to testing all the coding sequences of the gene called the exomes of the 20,000 genes that we have, and finally the whole genome. Can you just imagine the vast amount of information contained in the 3 billion base pairs of DNA present in each of our cells? In the recent years, scores of companies started offering genome sequencing services directly to the public. You just actually need to spit your saliva into this tube, put it in the box, and send it back by courier to the testing company. This has become a big business, and although this demonstrates a public appetite for this type of information, there needs to be serious discussions about the regulatory environment, patient privacy, and other policy implications of what we call direct-to-consumer genetic testing. In the judicious practice of medicine, a fundamental principle is to order only those tests whose results will guide clinical management. And the principle of actionability is consistent with the goals of minimizing the potential harms and wasted healthcare resources of unnecessary or low-value testing. There are 3 broad categories to illustrate how the clinical actionability of genomic testing is really not a simple yes or no determination, but rather it lies on a continuum influenced by the natural history and medical management of the condition in question. So genomic information can be used to guide pharmacotherapy, measure disease risk, and determine familial risk. And I'll talk about each of these briefly. So how is genomics used to guide therapy? There is a new field called pharmacogenomics, which uses an individual's distinct genomic profile to facilitate more efficacious or safer medication choice and dosing. You can see here on the right, like for a normal dose, you probably need that's the determined standard of care. But some people will need a lower dose because their genetic makeup does not. They're slow metabolizers, and therefore tumataas kagad yung concentration in the system of that patient, or they're fast metabolizers. That's why they'll probably need a higher dose for it to be more effective. But if it causes serious side effects, then you may have to explore an alternative drug. So there are now more than 200 medications that include information about how patient genotype might impact drug action, and a dozen drug gene pairs with sufficient high-quality evidence to support the development of drug dosing recommendations. An increasing number of drugs are being co-developed with companion genomic diagnostic kits. In this slide, you will see that over a 20-year period, the pie chart on the left shows the therapeutic areas where pharmacogenomics is being used. The majority is in oncology, followed by neurology, and then infectious diseases. But you also see here cardiology, hematology, gastroenterology, and all the other specialties. On the right, we appreciate the trends in the number of new drug approvals with pharmacogenomic labeling. The blue-colored bars in proportion to the non-pharmacogenetic drugs in the gray bars. Now, this is the best example of a very unfortunate event. Carbamazepine is the leading cause of Stevens-Johnson syndrome, a life-threatening mucoblistering disease in Southeast Asian countries. But carbamazepine is one of the more popular drugs used as for seizures. Now, people who carry the HLA-B*1502 allele has been reported to be associated with Stevens-Johnson syndrome among Han Chinese, Thai, Malay, Vietnamese, Indonesians, but not among Koreans and Japanese. And this association is not present among people of European ancestry. Oops. Sorry. And you can see how a child who received this carbamazepine drug looks like when the Stevens-Johnson syndrome develops. Now, sorry. This actually made companies develop carbamazepine prescribing information to have this serious dermatologic reactions and this warning in the box when you buy carbamazepine to treat seizures. And so people who actually carry that allele that I mentioned earlier, they should refrain from taking this drug, and therefore they should be given an alternative anti-seizure med. Now, how about Filipinos? A study came out in a few years back, and Dr. Capule is the dean of the College of Pharmacy in UP Manila, and they did find the association of carbamazepine-induced SJS with this HLA-B75 serotype among Filipino patients. So this can be used as a genetic risk assessment prior to prescription for prevention of SJS. Now, we've also extended some studies on pharmacogenetics together with the cardiovascular group in PGH, where we have Dr. Roddy C., of course, and together with 12 other cardiologists from PGH, and then, of course, our genetics team from the Institute of Human Genetics. You know, cardiovascular disease is still the leading cause of mortality among Filipinos. And we found that there's a variant in the Klotho gene that is associated with poor response of Filipinos to beta blockers, such as metoprolol, which is widely prescribed as an antihypertensive drug. If you lose one copy of the allele, if that is what you were born with as part of your genetic makeup, it may result to an almost fourfold increase in risk of not responding to beta blockers. We also found that a variant in the FGF5 gene for those patients who are taking calcium channel blockers like amlodipine, if you carry one copy of the allele in the FGF5 gene, it may result in 3.5 times higher likelihood of not responding to calcium channel blockers, and 7 times higher likelihood if you have 2 copies of that allele. This is a personal concern because I use this to control my hypertension. So, and I'm sure many other Filipinos also use this drug. Now, the other finding that we've had in our genetic studies for cardiovascular, with the cardiovascular group, is that a BAG3 variant can induce, if you carry the BAG3 variant and you are taking an ACE inhibitor, it can induce cough. So akala mo you have an infection and you keep on you're being treated with antibiotics, but actually what's causing your cough is that your drug, your ACE inhibitor is causing you to cough because you carry this variant. So these are just examples of the findings that we've had in our genetic studies regarding cardiovascular medicine medications. Now, the second point is about the use of genomics in measuring disease risk. How does information about our genes measure disease risk? Disease risk is the probability of the individual carrying a specific disease-associated mutation or of being affected with a specific genetic disorder. Now, information derived from a genomic test can be used to determine disease risk and identify subsequent risk-reducing interventions. A well-described pathogenic variant in the BRCA1 gene that causes breast cancer detected through a genetic test calls for a clinical action, including a heightened breast cancer surveillance or prophylactic mastectomy. Genotype-driven management can be offered to patients who carry a BRCA mutation. Identifying inherited susceptibility to breast cancer may influence surgical treatment decisions. BRCA pathogenic variant carriers treatment may include here, if you identify already BRCA1, you're a carrier of a BRCA1 mutation, actually it can you can opt for a prophylactic mastectomy on the unaffected breast. Second, carriers of BRCA pathogenic variant carriers, the treatment may include the use of platinum-based agents that may be used in the treatment of metastatic breast cancer. it's helpful to know if you carry that BRCA1 mutation because it can be used to direct your treatment. Also, if your breast cancer naman is caused by caused by a TP53 mutation, then it can influence radiation treatment decisions and reconstruction options. One of the other things that can be done is also regarding management options which exist, and the strength of evidence varies across the types of intervention. This slide shows data that can be provided to patients if they are found to have a BRCA mutation and the corresponding reduction in the cancer risk with each risk reducing intervention. Like as I mentioned earlier, you can opt for a prophylactic mastectomy if you carry, if the BRCA gene mutation is found, and you can have an 85 to 100% reduction in breast cancer risk, also risk for ovarian cancer, and also the use of chemo prevention. The last information, the last actionability with genetic testing is for determining familial risk. Information about our genes can be used to know your familial risk. Familial disease risk denotes the risk of disease when a family member is affected compared to the risk level in the general population. First-degree relatives, parents, siblings, children of an individual diagnosed with a BRCA-associated genetic change have a 50% risk of having the same genetic change, and therefore they can have those management options as a risk for risk reduction. And testing really actually begins with a person diagnosed with cancer in the family. Now, I don't know if you can tell me whose pedigree this is. This person who's seeking consult for BRCA gene testing. Her mother had breast cancer in her 40s, also developed ovarian cancer and died early. The sister of her mom also had ovarian cancer and also passed on. Their mother also had ovarian cancer at a young age of 45 and subsequently died. So she wanted to know whether she will have that risk of having breast and ovarian cancer. This person, I don't know, looking at this, you probably will know she has 3 adopted children, but she has twins of her own and another offspring. Can someone just type in the box whose pedigree this is? Well, if you guessed it was Angelina, it was this is Angelina Jolie's pedigree. So because she got tested that she does carry the BRCA1 mutation passed on to her by her mother, she opted to have prophylactic mastectomy and oophorectomy so that her risk for breast and ovarian cancer was dramatically reduced. So do we have information about genes and breast cancer among Filipinos? We did a study many years ago, and unlike Angelina Jolie, who had a mutation in BRCA1, which is more common in the Caucasian population, BRCA2 mutations are more common among Filipinos with breast cancer, and we even identified a founder mutation. A founder mutation is a mutation that appears in the DNA of one or more individuals, which are founders of a distinct population, like our population, the Filipino population. More recent data from the group of Dr. Dufitas in PGH also demonstrated a similar finding. So genomic testing does have unique and quite challenging issues, such as the following: patient and physician education, counseling, privacy, confidentiality, justice, cost, patient's best interest. We need to keep them in mind because not many physicians in our generation are very well informed about the genetics and genomic testing, what are the implications. So we have to have a massive educational campaign once genetic and genomic testing gets integrated into our healthcare system. Genomic testing may predict diseases or detect susceptibility without the ability to prevent, treat, or cure the conditions identified, some of the conditions. So right now, it's very helpful in oncology, but it's also becoming more helpful in other conditions like cardiovascular, and also in the field of neurology. Identifying disease risk not only for patients, but also for family members who may not be aware of or interested in obtaining information on their disease risk. We handle this very much during the counseling session because we may have patients who want to know because they want to be in control of their health or their lives. But there are those patients who do not want to know because what they don't know won't hurt them. So this is something that we handle during the pre-genetic testing counseling sessions. So underrepresentation of non-white ethnic groups in scientific research and clinical trials have also seen a disturbing trend with human genomic databases heavily skewed toward people of European descent. Now, this inherent bias needs to be addressed, especially because of global efforts toward precision medicine. And Filipinos, like many Asians, are an under-sequenced population. If you have had the opportunity to be tested or sent off some of your patients for genetic testing, this is maybe one of the reasons surrounding results that say variants of uncertain significance or VUS. In VUS, they found a change in your genome after the test, but its impact on health is yet unknown. And therefore, sequencing Asian genomes can increase the diversity of genomic databases towards targeted, more effective clinical approaches to treat and prevent disease. And our aspiration is to have our own Filipino genome reference sequence. The Filipino will be our flagship program here at the Genome Center, hopefully to commence soon with support from the Department of Science and Technology, Philippine Council for Health Research and Development. It's an initiative to sequence 10,000 Filipino genomes so that Filipinos can benefit from precision medicine. There is still a lot of work to be done, and we have to make sure that precision medicine will be inclusive and equitable, especially as we anticipate the full implementation of universal health care. So these are my key messages. Genomics in medicine has far-reaching implications and a wide spectrum of uses for diagnosis, patient stratification, risk prediction, response to treatment, prognosis and identification of novel genetic associations and mechanisms. Clinical actionability of genomic testing falls under three broad categories I have described: guiding pharmacotherapy, measuring disease risk, and determining familial risk. The identification of individuals at risk for future disease where clinical actions are available can significantly decrease their risk, and the information may really be helpful to these families. And lastly, the underrepresentation of Filipinos in genome databases can be addressed with the Filipino, our very own reference sequence, and this can pave the way for the implementation of precision medicine in the future. And with that, thank you very much for your kind attention.
Wow, thank you so much, Eva. Naku, galing-galing talaga ni Eva. My goodness, talagang we really learn a lot from this webinar, no? Ako talagang ang galing, ang daming insights, no? Many things for us to consider and think about. And we just like to thank you so much for the time you put into preparing this presentation. So don't go away. We will still have a little bit of time for Q&A, but Raymond's going to introduce our reactor. Go ahead.
Yes, thank you so much, Dr. Eva. And for our next speaker po, she will be our reactor. First time po sa ating webinar. She's the new Executive Director of the Philippine Genome Center. Please welcome po to your screens, Dr. Fe Lakbawan. There we go. Okay.
Hello. good day, because I know it's people are tuning in from different places around the globe. Of course, Eva gave an excellent presentation to you all in terms of an overview on how genetics and genomics is being used currently. I kind of come back to the Philippines, having 35 years in the US practicing molecular genetics and clinical genetics. So this is like the stars are aligning. The Philippine genome is actually equipped to move on and advance more diagnostics. And of course, Dr. Eva has been part of this. And I also had participated in Philippine Genome Center since 2014 or 2016. So that being said, I think we need to like highlight what Eva had mentioned in terms of how genetics and genomics will affect practice of medicine in the Philippines. Right now, it's a bit expensive to get some testing, genetic testing in the Philippines, especially the constitutional and cancer-related testing, right? So it's our dream, Eva, together with the rest of the other people in Philippine Genome Center, to repurpose some of the infrastructure that has been there for the pandemic and use it to really shape the precision medicine practice in the Philippines. So we will try our best to make sure that some of the basic genetic testing can be offered and the equitable and accessibility of genetic testing can be answered. Since we are at UP and the government also finances our R&D or research and development as well as extension work, we think that we're poised to really make use of what we have and be very vigilant and bring on some of those diagnostics that are not in the Philippines and are readily available abroad. So I will tell you, saludo ako kila Eva, kila Dr. Padilla, because despite the fact that resources are not there, I mean, there's resources, but not as abundant as other countries, they were able to put up a lot and advance the practice of genetics and genomics in the Philippines. And now I think it's not just a practice for clinical geneticists, but it's a practice for all of medicine, right? So be it somebody coming from internal medicine, oncology, OBGYN, it's like it cuts across different specialties in medicine. So yung tanong na may familial predisposition or genetic predisposition, any of those diseases can now be tested, at least most of them, I think. And then Eva emphasized the fact that you tailor fit the drug that you will use. Actually, may natutunan din ako kay Eva kasi I'm not very familiar with a lot of the Philippine studies that were done. So FGF5 and BAG3, wherein these are commonly, antihypertensive drugs are commonly used in the Philippines, right? And even me, I have antihypertensive drugs and I use some of those drugs that Eva had mentioned. I didn't know that actually FGF5 and BAG3 are kind of like, there's some things going on that we don't know, and be very, very, at least we get educated, because practically I should get tested for both because I have that chronic cough, and I thought it was more irritable, hyper irritable syndrome for the upper respiratory tract, but maybe it's the BAG3, right? And then of course the amlodipine, they changed my medication because amlodipine, I'm not responding very well. So those kind of practical things, and maybe genetics testing can help, but it's not very readily available. We're hoping that with the more common use of sequencing and the decrease in the cost of genetic testing, we will be able to be offering it to people who really need it. I think we start with conditions that are familial. You've heard breast cancer and some of the colon cancer and some of the other cancers that are familial, but also some familial hypercholesterolemia. There's a lot of young kids kind of dropping dead with no reason at all. Could it be that it's familial hypercholesterolemia? And 50% of there's only 3 genes that are very common, and 50% of those who have defects in LDLR is a receptor of the lechon de leche gene that Susie had mentioned. So point being that there is a way to prevent the consequences or the negative impact. And of course, we prevent it. The interaction with environment is also important. So that being said, I think that there's a play. There are talents in the Philippines. I came back. As I said, I practiced molecular pathology in the United States more than 30 years. And I've developed certain laboratories that actually do offer molecular genetics testing and cancer genomics. I think it's time for us to bring it to the Philippines and get it set in the laboratories within the Philippine system and help a lot of people who are really going to benefit from it. So I will tell you, my family is also going to benefit from this. I have a sib who's breast cancer, 50 years old and younger, and I tested her in the US. Unfortunately, the mutation that she has, BRCA2, is actually not not common in the Philippines, but it's not known whether it's really causing her cancer. So now it would be a familial study, and I would have to convince my other sibs. I mean, we don't have any other members of their family that are affected, but it will tell us whether that gene variant in BRCA2 is segregating or is causing the cancer in our family. So those are the kinds of the discovery, as mentioned by Dr. Eva. We just don't diagnose and give prognosis and treatment. We also discover, right? So we know that some mutations are very private in families, and knowing that if there are really familial conditions in the Philippines, and we have those mutations, we're contributing to a body of knowledge globally and not just in the Philippines. So it's time to advance genetics and genomics, and we know that for every person who would benefit from it, there's a family that's also coming to benefit from it for both cascade testing as well as treatment. So maybe I think we've emphasized the use of genetics and genomics. It's a matter of trying to bring it to the Philippines and make it accessible. Eva will tell you that they send genetic testing abroad. So there are tests that are being done at NIH and PGH, but not everything is still available. So we hope to serve more of the Filipinos, and I think for a better Philippines and healthy Filipinos. That's how we would want to go about this.
Okay. Thank you so much, Dr. Alakbawan. Very, very, very timely comments din po. And I was surprised with your line earlier when you said that you learned something about the Filipino studies that are very, very new po. Dr. Susie?
Yeah, thank you so much, Dr. Fe, and of course, Eva. Wonderful discussion, eye-opener. I think we really need to move forward and be more modern in how we're thinking about how populations are going to be healthy in the future. And let's open up for Q&A. We have some time, Raymond, to take a couple of questions, but just to get the ball rolling, I was going to ask Eva, we do newborn screening, right? But what would be available to ordinary Filipinos right now that you think would be worth doing on a larger scale?
Thank you. Maraming salamat po sa tanong na yan. We have discussions now going on with the cardiovascular group because we think that familial hypercholesterolemia is one of those conditions that can be started on a population basis. The US CDC has actually classified screening for familial hypercholesterolemia under tier 1, just like newborn screening, which means people, if you get tested for it, even if you don't have any manifestations, or right now your cholesterol level is not high, but I mean, you think that your cholesterol level is not high because you eat well, you know, your body, you're very careful about your lifestyle. But then one affected person in the family can trigger off testing, because the global prevalence of familial hypercholesterolemia is actually 1 in about 300 individuals. And
Ouch.
it's autosomal, and it's autosomal dominant. So if one of your
Yeah.
parents is affected, then you have a 1 in 2 chance, or 50% of getting it. So I think it's very important because there's treatment. You can be started on on statins, or what do you call it?
HMG.
Cholesterol lowering agents.
Yeah. Wonderful. I mean, I think that's good news for everybody. I'm one of those, 1 out of the 300, right? As I told you, my father's cholesterol could not be measured. That's how high it was. And I discovered I had high cholesterol fairly recently. So my doctor has put me on statins and on a plant-based diet. So I cannot eat lechon de leche. Raymond, paano ba yan, mga Mikiani? We have to eat pork. But anyway, I think that's good to hear. I think when we think about cardiovascular disease, heart attacks, coronary artery disease in the Philippines is a huge, huge, huge problem. So I think this is a very positive thing, Eva, that you're thinking about this on a population scale. Okay, Raymond, let's pick up some questions if you have one, or from our audience.
I have po from the audience.
Okay.
How available daw po yung direct-to-consumer testing in one of the slides of Dr. Eva? Is it something na pang-US lang, o meron daw po ba yun dito sa Pilipinas?
Maybe I'll let Dr. Fe talk first, and then I'll add on. Yeah.
Eva will answer the availability, but I think that we have to be very cautious about the use of direct-to-consumer testing. The way it is laid out in the US, practically there's a big 23andMe and Ancestry genetic testing and all those kind of things, right? It depends on what you're looking for. And if it's something diagnostic in the family, this is not the test that you would want to, right? So if it's more kind of recreational, there are certain characteristics that they actually describe, and you have the gene or you don't have the gene. There's also this notion that nutrigenomics is part of this whole thing. You have to take it with a grain of salt, right? So I think it created an educational opportunity, but people need to understand that there's limitations, and they don't really look at the whole genome. They look at lamppost, parang yung SNPs na sinasabi ni Dr. Eva, no? Parang yung mga changes na sa different genes, but they don't really look at the genes itself. So it's hard to say that it's really advantageous to take it. If you're just going to take it for recreational. I took it for Ancestry, but what did I get? It just said you're Southeast Asian, right? It's like basically, he didn't even say you're 5% or of this or that, or Chinese or Spanish, ganun, wala. It parang Southeast Asian, ganun. So you get what you pay for. It depends on how you would want to use the genetic testing, right? So if you truly want a targeted genetic testing, do it the right way. If you want it just a recreational, so be it. Understand. It's a very nice, they give you a very nice material to understand genetics, which is good, right? For us geneticists, it's nice to have people understand how genetics work, but just be cautious about how it's interpreted. And if truly there is some implications and some health kind of consequence of what you're getting, you have to consult your primary care physician or your doctor, so that it's better that you understand what's in the genetic testing results.
Thank you. Raymond, do we have time for one more question? Maybe we do, right?
Yes, one more question po.
Okay,
Question would be, from Dr. Joseph Tortona, can genomics result to genetic manipulation to prevent genetically related diseases? Yun po yung nasa Q&A natin. Ma'am Eva.
Well, that's of course, anything is possible, but of course, this type of manipulation is well regulated at the moment, even on the research basis. Is it possible to because you are born with those genes, right? There are now some therapies that are available, like gene therapy, that can allow some. So if the gene is mutated, then you replace it. There is some manipulation that can happen so that the protein gets expressed, and therefore there's some function that gets restored for some diseases. And then you probably have heard about CRISPR technology that's already being used to discover novel treatment strategies. But really, to manipulate the gene before the baby is born, that has a lot of ethical issues that surround it. What's happening now is that with pre-implantation genetic diagnosis, that is done through in vitro fertilization. The embryos are tested when they are already in the 8-cell stage, 3 to 5 days post fertilization. They are now they remove the truffle ectoderm and test those, and they will only implant the embryos that do not carry that mutation that is present in the family history, if they have an inherited condition. So is that happening right now? Yes, it's happening right now for a limited number of patients, because we don't actually do it here. Pre-implantation genetic diagnosis, the procedure may be done, but the actual testing is sent abroad, and then the results come back, and then the fertility center is the one who implant the embryos. So I don't know, Dr. Fe, it's happening more in other countries than in ours.
Right. So Dr. Eva mentioned that there are certain diseases that you can do like stem cell manipulation and give it to the patient for as long as it's something that can be used or replaced, right? But for certain conditions, it's impossible. And then maybe the CRISPR technology is really relevant in cancer, because there's a lot of other, it could be in diagnostics or it could be in treatment, depending on what the target driver of cancer is in that patient. So limited practice and judicious kind of like utilization of knowledge and technology is still the key here.
Okay, thank you very much. Thank you very much, Eva, and thank you, Faye. Unfortunately, we're running out of time. I think Raymond's gonna launch an evaluation, but while he's doing that, we are going to thank you. We're just gonna say goodbye and thank you. But Raymond, please launch the evaluation.
Yes, can we have it on the screen, the panel discussion poll? Okay, so we have 5 questions po, 4-point Likert scale. We encourage everyone to put in your answers here. So as follows: the panelists demonstrated thorough knowledge of the topic. Number 2, panelists were well prepared and organized. Number 3, panelists spoke clearly and audibly. Number 4, the panelists used appropriate language with technical medical jargons adequately explained. And finally, panelists contributed to new perspectives and knowledge managing various key health issues. So we'll keep this open until the end of the webinar po. For next week, what do we have next week, Dr. Susie?
I forgot what you said. Ano nga ba?
Geriatric medicine. Geriatric medicine.
Geriatric medicine. Okay. So we're going to have geriatric medicine next week. And again, on behalf of TVUP, we want to thank Dr. Fen, Dr. Eva for your time, and on behalf of our audience, because we learned so much from you. So next week, please be with us. We're going to talk about geriatric medicine, mga seniors naman. Raymond, over to you.
Thank you. Thank you again to the Philippine Genome Center led by Dr. Felak Bawan and also our Executive Director of the NIH, Dr. Eva Maria Cochongo de la Paz. Very, very malaman po na webinar for today, and we hope if you have any questions po, please feel free to email us at stopcoviddeaths@up.edu.ph. All of our webinars are archived po for viewing in our TVUP YouTube channel po, no? So youtube.com/TVUPPH. Kasabay po nito ang ating mga short videos that very, very similar to TikTok. This YouTube shorts for very short, consumable, for you to be able to gain knowledge or nuggets of wisdom po for each of our webinars. So that concludes our webinar for the week. Magkita-kita po tayo again next Friday from 12 noon to 2 p.m. To 1 p.m. na pala. It's a date.
Together, we can stop preventable deaths.
So keep safe, keep healthy, and see you online.